We're going to talk about preventing concussions, and we've got roughly 30 minutes to do it and a bunch of slides, but the bottom line is going to be strengthen your neck and avoid taking as many hits as you can, and hope you got the right genetics. For those that want additional educational materials, we have a website which we put up for educational purposes, and you're welcome to go to it, download whatever you want off of it. Well,
players announced yesterday they will donate their brains to science after they die. Actually, they were going to ask Brett Favre to do that, but they're afraid after he died, he'd change his mind, want the brain back, and give the brain back.
Well, you know the subject has gotten popular when I guess it goes to the late night talk shows. We knew a couple years ago it was getting steamed up when it made the front page of Sports Illustrated, and very tragically, Ann's talk could not have come at a better time. We certainly don't know the pathology of his brain at this time, but hopefully it will be known at some point in the future, though it will not bring him back.
Still stopping. Oh my gosh.
That, I think, needs to be eliminated, which is a major theme of a book which will be out on September 15th by Houghton Mifflin. And for those of you who share my concerns about youth activities and head trauma in youth activities, it might be a read that you'll be interested in. Incidentally, it's basically what I know about concussion told through the stories of many, many, many of our patients. All right, concussion prevention is my topic. There are products out there which are touted to prevent concussion. Those topics include probably not too useful, but are the others much more useful or not? Well, the shock box is out there. It has accelerometers in a helmet, and the idea is that someone sitting on the sideline with your smartphone or computer can get a signal roughly indicating the amount of forces that have been received in this helmet, and maybe you should pull somebody from play or not to examine them. They may or may not have had a concussion. The only problem is the forces that have not been validated in terms of the accuracy of the linear forces and or the rotational forces. And by the way, the product that's been out there the longest period of time is the Simbex product, which many researchers have gathered a lot of information over the last 6 years using. And the Simbex product is owned now by Riddell, but developed by a local researcher at Dartmouth. This product measures linear forces with 6 triaxial accelerometers embedded in the helmet, and then from the linear forces and an algorithm calculates the rotational forces. But one problem, it's been validated only in the laboratory with hits that go directly through the center of gravity of the head, ear hole to ear hole, with a medium-size helmet only that fits with such tightness that no human being could wear it probably for more than 30 minutes were it on their head, because the head form really should have had a large size helmet. So the National Football League right now is going to great expense to validate the accuracy of the HIT system, as well as some other products I'll show you shortly. And the concern is that when hits are eccentric, not through the center of gravity of the head, that the helmet is spun and the accelerometer may come uncoupled from the scalp, may be lifted off of it. And also, if you wear the proper size helmet, like a big helmet for a big head, the uncoupling of the helmet happens more easily because it's not crammed against these accelerometers onto your scalp. So all of that HIT data right now as we're speaking is being validated, and hopefully for all the work that's gone on through the last 6 years, it will be validated with on-field real-life situations But if it isn't, it's going to put us in a situation that maybe that's why we've not been able to correlate concussion occurrence with necessarily what the hit system has been giving us, meaning that many times with forces well above 100 G, there's not been a recognized concussion, and sometimes with forces as low as 60 G, there has been. There hasn't been that one-to-one correlation or nearly as high. Other products that are out there include a chin strap that's got accelerometers, actually gyroscopes in them, and are purported to register impulses, linear and rotational accelerations. This is also being validated, this product. There are also mouth guards that have accelerometers within them, and those products are also being validated or not validated by the NFL currently. And because this is such a hot topic, by the way, that validation is going on at 2 independent labs that don't have any relationship to each other, and each one is blinded to what the other one found. It's Biokinetics, the lab up in Canada that's done a lot of previous work with the NFL, as well as Southern Impact Research Lab down in Tennessee. There are other products which are out there suggesting that they might be able to tell you whether or not you've had a concussion, such as the King-Devic test, which is a visual eye tracking test using saccadic eye movements. The nice part of that test, it's a very simple test. You don't really have to have a medical background to learn how to apply it and use it. The theory behind it might be, well, it's not quite that simple. But the theory behind why it might be very useful is that the visual tracking mechanisms of the eye use many circuits within the brain, and so it's a test that tests more areas of the brain than just visual cortex or just cerebellum, and would have a greater chance to be abnormal with a diffuse injury like a concussion. Again, there are additional validation studies which are necessary to be done for this product, but this product is beginning to be marketed. Other products that are out there are single lead EEGs, so-called brain scope. There are also products involving headbands. The headband, the full 90, has been mostly devised for soccer, has been marketed pretty heavily. It was initially studied some years ago by monies that came from FIFA, the International Soccer Organization, and the original studies of it were to see whether it reduced forces or accelerations from the act of heading, and it doesn't. It doesn't reduce a zilch of that, because what happens is that the ball deforms over the head protection itself, and so the head protection really doesn't have any chance to reduce the acceleration forces. In terms of head-to-head contact and elbow-to-head contact, that kind of hard surface contact, there is some slight reduction at the lower speeds, 2 and 3 meters per second, where there normally are not concussions sustained anyway. At the higher levels or higher speeds, 4 and 5 meters per second, this reduction is very, very minimal. So its abilities to reduce concussions has yet to be really established. This is just simply one of the mouth guards that is being marketed. The Cleveland Clinic has another one. I guess I should have said there are 3 things that really can reduce concussion that have been shown to do it. Technique proper technique is another. The great majority of concussions in many instances happen because individuals are not using proper technique, and probably in football is a great example of that. As we all know, that technically you're not supposed to use the head as the initial point of contact in blocking and tackling, and of course that happens all the time. Proper technique in terms of tackling would reduce an awful lot of concussions in football. rules changes, I think, can go a long ways to reducing concussions, and I'm quite pleased that to think that we're in a building today with one of the universities that has taken kind of a pioneering step. It's really the whole league, the Ivy League, that did it. They have essentially put together a committee that I'm happy to be a part of that has already made recommendations which have become in effect for football, but they're also doing similar recommendations for other collision sports, ice hockey, as well as women's lacrosse, men's lacrosse, in which the amount of head trauma is trying to be reduced. It's trying to be minimized. And so what's happened in terms of football for the Ivy League is the number of days a week you can have full contact practice is down to 2. There's hitting only 2 out of 5 days of the week. And in the preseason, when 2-a-days are occurring, you can hit only on 1 of those 2-a-day sessions. So they're trying to take the amount of head trauma and reduce it. If you reduce the amount of head trauma, you're definitely going to reduce the amount of concussions. As an aside, when Ann showed the marvelous work that she's doing with chronic traumatic encephalopathy, and she talked about the clinical symptoms, one of the things that she didn't get into, which I think is very relevant to this hitting issue, is that what we're finding, or Ann and her group are finding, and the rest of us are kind of looking over her shoulder about, is that chronic traumatic encephalopathy doesn't seem to be related to concussion. She showed you the picture of Owen Thomas and his brain, and Owen had no recognized concussions. Do I believe for a second that he had no concussions? No, I think he probably had them and he just didn't admit to them. But the bottom line is no recognized concussions. What we're finding is that CTE is more related to total brain trauma than it is to recognized concussions. And it looks like it's going to be position sensitive in football. Those positions, for instance, that take the greatest number of hits are more likely to wind up with CTE, irrespective of whether they ever had any concussions. And that's why the offensive linemen are the ones that are the great majority of the brains that we've studied so far. And that's why a sport like ice hockey, which does have CTE brains, probably will never have, when we do one day know what the incidence and prevalence is, it'll probably not be as high as a sport like football, because although the individual hits are as great or greater than football, there are not as many of them. And conversely, boxing is going to be worse than football for the same reasons. The NFL has taken a real lead in the rules change business. They kind of swept out a year and a half ago their old committee on concussions and put in a brand new committee. They've done a number of things to reduce the amount of head trauma in football. The 4-man wedge has been eliminated. The crackback block, you can't hit a person in the head any longer. Anybody that's suspected of a concussion, in fact, can't rule one out, is out of practice or play, can't be returned until an outside neurologic consultant has felt that the individual should be returned. There also are a number of individuals and a number of plays which are now regarded as quote-unquote a defenseless player, and anyone in this situation, used to be just the quarterback, but anyone in this situation, you can't legally hit them to the head, and a flagrant abuse gets the individual at risk of fine and or suspension. And those people are people in the act of throwing a ball, in the act of kicking a ball, in the act of receiving a ball, so on. So their eyes essentially are down the field or on another individual, and if they were to be hit in the head, it would be a blindside hit. And then in the last, this year actually, during the playoffs, largely in response to the Colt McCoy situation, where anybody seeing that Cleveland game could see that he had been clocked and was rendered motionless on the field for a period of time, but yet when he went off the field, he was complaining that his hand hurt, so that's what got examined, not his head, and he got put back in. In response to that, the NFL now has up in fact, we have an athletic trainer that's doing it right now for the Patriots here in our second row. Athletic trainer is in the booth up in the stadium looking at the same TV feeds that you may see on your TV. And that feed, his job is to essentially identify an individual who looks like they're getting up slowly or may have been concussed or may have been stunned, and transmit that information down to the head team physician or head athletic trainer on the field. And they also have feeds now that they can look at. So although their main job is to assess the athlete, they're also going to be able to look at the mechanism of injury and to see how the athlete responded immediately after the injury, and hopefully have a better chance not to miss concussions. Well, a few years ago, this guy's demise, that's Manny Sosa, not Ramirez, his precipitous deterioration was felt by many to be because of the lack of juice. It may be more true to say, though, that the concussion he sustained that year may have had a tremendous effect in terms of affecting his ability, reaction times, etc., to hit the home runs that he once hit. It's interesting for me to think that not the late Joe Paterno, but John Gagliardi is the winningest football coach in all of college football. He coaches at Division III university in just outside of St. Paul, Minnesota, Minneapolis-St. Paul area. He's been coaching now for over 50 years, and during the season, John does not have his team tackle or have any full contact. They do drills, they wrap people up, they don't take them to the ground. He saves that for game day. He has a trivial injury incidents and almost no concussions because of that. So if you reduce the hitting in practice because you have the majority of hits to the head and other parts of the body happening in practice, you're going to very markedly reduce your chances of concussion. You're going to reduce the total amount of concussion that you would otherwise see. Per hour or per minute of playing time, hits to the head are 3 times greater in play than in practice. But because you practice the great majority of the time so much more than you actually play the game, precipitous decline in the amount of concussions that are sustained can be occurring with this reduction in full hitting or full contact. Chris Nowinski, as you know, is probably the most prolific concussion advocate out there, the former Harvard football player that Ann mentioned, and he went on and tagged me along with him to found Sports Legacy Institute. And Sports Legacy's mission is to advance the study, treatment, and prevention, essentially of brain trauma, predominantly in athletes, but also other at-risk individuals. And with regard to the situation regarding reducing concussion and reducing subconcussive blows, we think that the time has come to address the issue of what we refer to as hit counts. And in the coming year, we will be putting together groups of individuals to wrestle with the problem of should we be putting limits, especially on our youth, of how many hits to the head they can take. Obviously, there's not evidence-based solid science behind it, but when we came out with pitch counts for Little League players for an injury that is surgically repairable, and in fact, last Friday I was talking down at Jim Andrews' sports medicine meeting down in Florida. Jim Andrews has repaired and done Tommy John surgery on a number of high school players who have gone on to big league careers, not just big league players that blow out their elbows, but high school players that have done it. I'm not suggesting we want to have high school players blow out their elbows and need surgery, but I am saying that we've gone to pitch counts for an injury that is potentially repairable and potentially the individual able to function as well as they ever did before, if not better. And yet we've not gone on to think seriously about head hit counts for a condition that can take lives and can alter lives in a very drastic way, especially if CTE is a factor. So our timetable is to have organizational meetings in the fall and hopefully roll things out over the next year or two. It is of interest that the literature is beginning to accumulate that is correlating deteriorating cognitive effects with individuals taking a certain volume of subconcussive hits. And as far as the studies are concerned, at least, these are individuals that didn't have concussions, at least no recognized concussions, just took a number of subconcussive hits over the course of a season. And as we have those instrumented devices proliferate, whether they be mouth guards, whether they be chin straps, whether they be headbands, whether they be helmets with accelerometers in them, even though the absolute accuracy of the rotational accelerations and linear accelerations may or may not be accurate, at least we're going to be able to know the number of hits that somebody took to the head above a baseline G sensitivity, and most of them are set at 10 G. So this hit count data is going to become available with very inexpensive recording devices in the immediate future. The issue of how many hits are too many is one I think that we need to start debating. What athletes need to know, obviously, to reduce concussion and reduce the effect of concussions, or what are the signs and symptoms of concussion, and to immediately be aware that they need to pull themselves out if they sustain any of them. And to that effect, the CDC has many different products now out that go to the athlete, and many of them are even sports specific. All of we physicians who take care of these athletes obviously have to be aware of the same things, and I'm very thrilled that this state is one now of 33 and was actually in it about the 16th that has come to have legislation mandating concussion education for physicians who are taking care of these athletes and returning them to play. And I suspect part of the motivation and for such a marvelous turnout of physicians in this room is that they will be receiving credit for that, for having attended this meeting. And I think that's a great effort on the part of the state. Concussion prevention also can occur by individuals having stronger neck muscles. For quite a few years, we've been playing with Newton's law of force equals mass times acceleration. If you divide the force by increasing the mass, the closer it gets to the mass of the body, the much less the acceleration is going to be. That's kind of the same thing as if you were to immobilize the head on the rest of the body, you'd be doing the same thing. You're trying to do that with your neck muscles. If your neck muscles are strong, you have a less chance. You have lesser acceleration, less chance. Working with Don Comstock and her RIO recording system, we have 1 year's data that's very, very exciting in the sense that the quartile of individuals, and this is not just in football, this is across the recording that she's doing for sports, the individuals with the weakest necks have the highest incidence of concussion. So far, we're not able to stratify it perfectly from top to bottom, but clearly those with the weakest have the lowest number, those with the strongest have the fewest number of concussions. The second year's data will be looked at in the next 2 months, and we hope by the end of the year to have a paper out on that. Other issues with regard to concussion prevention is adequate hydration. To the extent that you are severely dehydrated, it's theorized you're shrinking essentially the brain and giving it more room to be jostled inside the skull. Poorly fitting headgear is another issue. Obviously, the headgear should be affixed to the head. What the genetics are with regard to concussion, we really don't know any more than we know with regard to CTE. It's not as simple as ApoE4. Obviously, luck plays a factor as well.
There are many things that I think you can point to as proof that the humans are not smart. But my personal favorite would have to be that we had to invent the helmet. What was happening, apparently, was that we were involved in a lot of activities that were cracking our heads. We chose not to avoid doing these activities, but instead to come up with some sort of device to help us continue enjoying our head-cracking lifestyles. The helmet. Even that didn't work because not enough people were wearing them, so we had to come up with the helmet law, which is even stupider. The idea behind the helmet law is to preserve a brain whose judgment is so poor, it does not even try to stop the cracking of the head it's in.
Well, a helmet does a marvelous job at reducing skull fracture to almost nothing, almost zero. It reduces the most life-threatening intracranial lesion, namely the subdural hematoma in athletics, by about 80%. So it's done a very good job in these catastrophic injuries. It's not doing a very good job with the concussive injuries, and it's probably because, as Bill very nicely showed you and described graphically for you earlier, that it's the rotational forces that are primarily responsible for concussion. In every hit, there's linear and rotational both, but it's the rotational that felt to be the most injurious. And what a helmet does is a fabulous job of attenuating focal impacts. So those sports which have concussions occurring because of a focal impact, ironically, like girls' lacrosse and girls' field hockey, where it's the stick that's causing the majority of the concussions in those sports, and they don't have a helmet. If they did have a helmet, you'd almost totally eliminate concussion, because the helmets do a fabulous job of attenuating the focal accelerations. Where they don't do a good job is the rotational forces. So when the head is hit and spun, like a blow to the face mask, a blow to the front of the helmet, a blow to the back part of the helmet, not a blow directly through the center of gravity of the head, those blows are not very well attenuated at all by a helmet, probably never will be, although admittedly helmets are getting better and more materials may in the future be better and better. But because of the fact of the rotational blows being the most injurious, probably the helmet will never be the savior in terms of preventing concussions. Thank you.
So Bob, while we switch over to Alex Taylor, can you just comment for the audience, because I know this is a big question often, on mouth guards. How important are they?
Yeah, I think mouth guards, I should have really commented about it. Thank you, Mark. Mouth guards do a great job of protecting dentition and oral structures within the mouth, but they don't do a good job at all of reducing the incidence of concussion. And in fact, there's really no good statistical study to show that they in any way significantly reduce. So for concussion purposes, mouth guards have one theoretical benefit. They slightly open your upper and lower teeth. This pulls the ramus of your jaw slightly away from the base of the skull, so it's got about 3 more millimeters to travel if you take a blow to directly the point of the chin. But the problem is that the majority of the sports, and certainly the helmeted sports, the chin is protected. That's not where the concussions come from. They come from mostly blows to the front, back side of the head, top. And so the mouth guard's not going to protect you in those locations. So the mouth guard doesn't do a significant job of protecting concussion.
Thanks, Dr. Cantu. So when we were starting our concussion clinic at Children's Hospital of Boston, I traveled to Dr. Cantu's clinic. I learned and watched how he did things. And then I went to the University of Pittsburgh, and I learned and watched how they did things. And while I was down there, there was a fellow in neuropsychology who was training at the University of Pittsburgh. And sort of behind the backs of everybody there, I gave him my business card and said, hey, man, if you need a job when you leave here, give me a call. And fortunately for me, he was from Massachusetts and called me and got a job, and now he's an essential part to our clinic. He is the neuropsychologist who cares for all the athletes we see that have prolonged symptoms or profound cognitive disturbance. And it's my pleasure to introduce him today to you, Dr. Alex Taylor.
All right, so thank you, Bill, for that warm introduction. Am I live? Can everybody hear me? Is this microphone on? That might help. Audio, guys, are you going to help me out with my mic? Not in this particular building. Am I live? All right, I'm live. All right, so I'm going to talk about the neuropsychological management of concussion. As everybody has alluded to, concussion, off to a good start here.
Is the chip in? Here it
Oh,
is.
there you go.
I'm gonna fix your
Jeez. All right, now we're off. So, neuropsychological management of concussion. Why do we use neuropsychology? As Bill has said, as everybody has said, these concussions are associated, these injuries are associated with normal neuroimaging findings. So you're not going to see anything on a CT scan. You're not going to see anything on an MRI scan. If there's not a dramatic marker of injury, if someone isn't knocked unconscious on the field, if someone doesn't have a seizure on the field, if someone doesn't get sick and vomit on the field, oftentimes what you're doing is relying on the athlete to tell you about their symptoms. I feel dizzy. I feel woozy. I feel out of it. I'm not thinking as clearly as I was before I was struck in the head, struck in the body, and I had a whiplash motion to my head. So athletes, as we talked about and heard from Dan, at the professional level, they might minimize their symptoms in order to return to play more quickly. So what we try to do is come up with measures that can objectively determine where somebody is in their recovery, how much deficit they're actually experiencing with regard to memory functioning, processing speed, reaction time. And that's where neuropsychology becomes important. It objectively helps determine the individual trajectory of recovery because everybody recovers at a different rate. So two people who have exactly the same mechanism of injury, they're hit with the same force, they may not recover at the same speed. So if we have objective information that can show when they've completely recovered, we can more safely return athletes to play. So let's just review quickly the anatomy of a concussion. What are we talking about here? And it's not, as we've all sort of pointed out, it's not just the contact sports. We're also talking about the weekend warriors, little kids learning how to ride their bikes, not using their brakes, getting injuries. Jesus. All right. So the initial markers of injury, what might you see? Retrograde amnesia, so forgetting what happened immediately before the injury. Possibly loss of consciousness, not in this case. 90% of concussions, 90% involve no loss of consciousness. Most of the people that you're seeing never lose consciousness. Post-traumatic amnesia, forgetting events that happened after the injury. Post-concussion symptoms, which can last hours, days, weeks. And then we also have to consider the pre-injury risk factors. So is there a history of concussion? Is there a history of psychiatric issues, history of learning disability, attention deficit hyperactivity disorder? Because all of those pre-existing risk factors can be associated with a longer recovery. And the symptoms, They generally fall into sort of 4 main categories: emotional symptoms, changes in mood functioning, feeling more anxious, feeling sad, feeling depressed, irritable; cognitive changes, so difficulties with memory, difficulties with processing speed, reaction time; somatic symptoms, the headaches are the most commonly reported symptom of concussion; and then sleep-related difficulties. And the reason I sort of have it drawn out this way is they all interact. It's not just one symptom or another symptom. If you're tired, you're not going to be able to think as clearly. If you're tired, you're probably more prone to experiencing headaches. So we're trying to manage in someone's recovery all of these different symptoms together, sort of getting the one at the top of the triangle that might be driving the other symptoms or associated symptoms. So the neuropsychological findings, what we typically find is changes in attention, concentration, working memory, which is sort of like your online memory bank, new learning and memory, retrieval, speed of information processing, reaction time. When they look at huge groups of people, most athletes recover within 10 to 14 days. But we know individually the trajectory of recovery can take significantly longer. We also know that in younger athletes, the recovery process, because the brain is still developing, is longer than that for the older athletes, so we need to manage these cases more conservatively. So when we talk about neurocognitive testing as related to sports, generally what we're talking about is computerized measures. Historically, a neuropsychological evaluation is a very comprehensive task that involves talking to teachers, families, conducting a sort of broad range of assessment that captures one's abilities across all domains of thinking. When we're dealing with concussion, we tend to focus more on those areas that are just affected by injury, head injury, processing speed, reaction time, memory. Computerized assessment is a way of seeing large groups of individuals in a relatively short amount of time, so it makes it more accessible. The advantages: capacity to test larger numbers of individuals, accurate measures of reaction time, reduced costs, access, different languages. And where is the value added, or what is the value added in neuropsychological evaluation or neurocognitive testing? If you rely, and this is athletes who've been diagnosed with a concussion on field, and then they've gone back and had their assessment post-injury, those athletes who are just reporting symptoms are diagnosed with 64% accuracy. If you use neuropsychological testing, the accuracy, diagnostic accuracy, increases to 83%. If you use both, 93%. So what this is arguing for, I need some water. What this is arguing for is not neuropsych testing as a standalone tool, but part of a comprehensive assessment that incorporates clinical interview, recognition of symptoms, and also testing to look at the changes in brain functioning. Again, this highlights that, a group of athletes who've actually been diagnosed with an injury. If you then assess them with neurocognitive measures, and there's a change in one domain of functioning, whether it's verbal, visual memory, reaction time, or processing speed, you can see that the predictive value is 89.4%. So when somebody has a concussion and there is a decline in their one domain of functioning, the take-home message is it is an accurate measure that can help diagnose this injury in the absence of symptoms. And this slide is one of my favorite. It actually really highlights or stresses how useful, clinically useful, neurocognitive testing is. So what we're looking at is the impact, which is a computerized measure of neurocognitive functioning, impact performance of two groups of athletes with concussions, two groups, one with concussions, a control group, and then the group with concussions is broken into two subcategories. One who is reporting symptoms, the other is not reporting symptoms. All athletes are tested 4 days post-injury and compared against a control group. So you look at the athletes who are symptomatic. I have headaches. I don't feel right. I'm still feeling slowed down. Clearly, their performance in the yellow is the worst of the three groups. They perform poor on these measures of verbal memory and visual memory. And then if you look at the asymptomatic group, so these are the individuals who had an injury but are denying all symptoms, or maybe not even feeling any symptoms, so there are no headaches. They feel they're back up to speed cognitively. There are no emotional changes. They're feeling great with respect to sleep. But even that group performs worse than the control group on these measures. So what this is telling us is in the absence, again, of reported symptoms, there are subtle neurocognitive changes as a consequence of a concussive injury. This, again, highlights differences in processing speed. So the symptomatic group performs the worst of the three. And then with reaction time, the reason the yellow is higher, so a slower reaction time is going to be a higher elevation. So again, the symptomatic group and asymptomatic but concussed both perform worse than the control group. So recovery. Thank you. So critical management, first 7 to 10 days, and this will be addressed later on, is really when most second injuries take place, within the first 7 to 10 days. Looking at older athletes and groups again, the average length of recovery is only 7 to 10 days, 10 to 14 days. It is variable. We think it takes longer if you're looking at the subtle changes in functioning that occur. 92% of repeat concussions occur within the first 10 days of injury. So the critical period is recognizing when an injury takes place and removing those athletes from play, being conservative. So when in doubt, sit them out. How long does it actually take? When we look at, so again, 10 to 14 days, but then when we look at neurocognitive recovery, you can see that it's really a lot longer than that. That if we look up to week 4, week 5, not all athletes have recovered. In fact, at the end of week 3, getting into week 4, we're looking at about 80%, and some are still incompletely recovered. And those athletes who have a previous history of concussion take slightly longer to regain their abilities. So what are the factors that actually affect neurocognitive recovery? Age, history of prior concussion, gender, exertion. So how hard are you working cognitively? Are you back in school? Are you back on the field prematurely? All of those things are associated with a slower recovery. The psychological adjustment, so psychology or changes in mood can be a reaction to the injury itself or a reaction to sort of the changes or the adjustments that you have to make in order to recover. History of learning disability or ADHD, and a headache history. So just to look quickly at some of these factors that are associated with recovery, this study looked at 2 groups, college and high school students. The Hopkins Verbal Learning Test, it's a 12-item word list so that these individuals are presented with 12 words 3 different times. After each trial, they're asked to recall as many words as they can. Then there's a approximate 20-minute delay, and they're asked to freely recall all those words that they've heard before. So 12 words, 3 learning trials, 20 minutes later, a delayed recall, and then there's a recognition task. So what this is showing is a baseline score, so all athletes were tested prior to the beginning of the season, and then it's showing their immediate 24-hour post-injury performance. Both groups decline. And then what you see is the college, the older athletes, actually return to their baseline much more quickly than the younger athletes, the high school athletes. They both eventually get there, but it takes the younger athletes longer to regain their abilities. And we think in even younger students, elementary school or middle school, that recovery curve may even be longer. So why are we worried about the younger brain? Basically, it's still developing. What this boils down to is the younger brain is still developing and therefore needs to be managed more conservatively. So the younger brain is also involved in a lot of activities that we all are, but learning and memory and paying attention and social interaction is such an integral part of what a younger person is doing that the brain is really always working. It's sort of working overtime if you think about it, and that might be associated with that longer trajectory of recovery. So, so what this is arguing for, again, is younger kids should be managed more conservatively than older athletes. And we're looking at how the attention and concentration deficits affects learning in the classroom, shorter focus on lectures, shorter focus on classwork or homework. You can't then hold instructions in mind. You know, the teacher is telling you to do 4 different things, and you're still thinking about the first one when they're on the 4th, or by the time they get to the 4th, you've forgotten about the first. It's harder to retrieve, consolidate, store memories, and then processing speed. You're just slowed down after having a concussion. And fatigue in the classroom. Shorter attention span, working the brain harder just to do the things that are normally automatic or routine. This is part of a child's everyday experience in the classroom. which you would see at all levels, but I think the demands are probably more intense for the younger kids. History of concussion, we've sort of covered this already, but there is a risk, a cumulative effect. So when you've had a previous concussion, neurocognitive performance tends to be more dramatic. The declines tend to be more dramatic immediately after a subsequent injury, and the recovery process can take a bit longer. Does gender matter? Turns out that gender does matter. Women tend to show, females tend to show greater deficits on neurocognitive tests than males after concussion. We don't know the reasons why. Some of it may be due to the fact that the neck strength that Dr. Cantu and Dr. Meehan talked about, where the blow is imparted, all of the force of the blow is imparted to the brain, whereas in males where there are stronger or more developed necks, that force is transmitted down through the body. And exertion, sort of gone over this, it's not just physical. We need to remember that exertion includes return to the classroom. When you're having to think, when you're having to do homework, when you're putting any kind of demand on the brain, it can slow down your recovery. It can cause the symptoms to last longer, which also means you're extending that period of increased vulnerability to secondary injury. The emotional consequences, and these are the ones, emotional consequences are the ones that strike us, I think. When Dan was speaking earlier about feeling irritated and just not really knowing why. Like, usually I didn't get enough sleep. I'm in a bad mood. I have a big test coming up. I'm in a bad mood. But if you're just feeling annoyed and you don't know why on a day-to-day basis, that's what strikes us, I think, as practitioners, and that's what we're trying to prevent, is helping people identify when these injuries have taken place and how you can get in front of it and prevent the longer-term consequences, especially those that are emotional, from occurring. Learning disability, headaches, both are associated with higher risk for longer period of recovery, and again, we need to manage these injuries and recognize this. This is all part of the clinical history taking that should be incorporated into one's assessment for someone who's been suspected of having a concussion. It's also going to impact their baseline performance on neurocognitive measures, as well as their post-concussive scores, post-injury scores. The treatment, to highlight the treatment, rest. The key is rest. Removal from sports, academic accommodations, sometimes removing someone from school altogether. And then when somebody becomes symptomatic at rest, after exertion, and demonstrates intact or return to baseline performance on neurocognitive measures, that's when we start getting them back into play, doing a modified return to play, following different stages that elevate the heart rate, elevate the level of thinking, until somebody is back to their normal level of functioning. And that is the end of my talk. So.
I think he would have talked longer if I brought him more water, but just trying to stay on track here. So we actually, with that talk, we actually do have about 7 or 8 minutes for questions from Dr. McKeelap, but I think everyone else is here, so questions for anyone. And there's microphones, which may make it easier. There's a gentleman in the back who I know was trying to ask a question earlier. Yeah, I think we got it. So the question, just for everyone here, is: does the protective gear in some way make you more prone to concussions because you're a little bit more volatile on the field?
So there's three things I know of. So certainly in bicycling, in horseback riding, and in ice hockey, people have tried to answer this very question. And for horseback riding and bicycling, people who have helmets on take more risk. They do. They take more risk than when they're not wearing helmets. In ice hockey, I'm most familiar with that study. The guy's name is Biasca, B-I-A-S-C-A, and I can't remember the year, but I think it was the British Journal of Sports Medicine. And he did something intuitive. He said, look, when I was a kid, me and him, there were no helmets in ice hockey. There weren't any. Then they were there, but they were optional. You could be grandfathered in, and actually Craig McTavish for the Boston Bruins was the last guy to play without one. And then they became mandatory, okay? And within 3 years of helmets becoming mandatory, the rates of high sticking tripled, right? People don't want to purposefully crack another guy's skull open, but if he's got a helmet on, they're going to play more aggressive. And now, of course, you know there's a penalty called boarding. Didn't exist back then. You would never throw some guy headfirst into the boards. But as soon as he's got helmets and big shoulder pads and stuff, you don't think you're going to hurt him, and you throw him headfirst in the boards. So it does change their behavior. And even within ice hockey, a sport within its same sport, the risk of concussion likely goes up when you introduce helmets to a sport, except for some potential exceptions that Dr. Cantu spoke about. However, there were rates of catastrophic brain injuries in those sports. So people had skull fractures and bleeding in the brain and death prior to the introduction of helmets. So you need to introduce helmets to prevent those injuries, but the price you pay for it is more aggressive play and potentially an increased risk of concussion.
Yeah, 30 years ago, I could talk that quickly and encompass everything. I wish I still could. Bill kind of said it all, but what I was going to go back to is 1905 was the first great crisis in football, American football, and it darn near was abolished, and Teddy Roosevelt saved it. And the reason it darn near got abolished was because 25 college players at a time when there weren't very many college players died. And they died mostly of skull fractures and intracranial bleeding. And the bottom line is, with that many people in that close a proximity, you have to have the head protection to prevent catastrophic injury. It is true that when you provide head protection for people, they tend to be more aggressive, but that's where the rules and enforcement of the rules, and Roger Goodell is proving that you can do it. You're probably never going to get some of the hardened people in the NFL to go by it right now, but as young people make their way up and into the league in the future that have been used to playing under new rules, I think you're going to see it. Can't eliminate the helmets.
Okay, we've got to move to the next question. Thanks. Go ahead, sure, yeah.
Given that after a first concussion, there's no imaging studies that show actual structural injury and neuropsychological functioning improves to normal. However, after a second concussion, the symptoms are worse than a person suffering the first concussion, shows that there's never really complete recovery. Are there EEG signatures that could indicate a brain affected by concussion?
I don't know the answer to that.
I think that I need to have Bill come and say his say after mine. But I think it's when we talk and we lecture, we often talk in generalities and so on, and not in specifics. The people I see in my office, many of them, their second concussion is much less than their first. Patrice Bergeron is the best example of that. The first time we saw him, he had symptoms for 4.5 months. The second time we saw him, he had symptoms 14 days. And the third time we saw him, he had symptoms for 4 days. First time he was out a season. The second time he was out a month. The next time he was out 2 weeks. So it really doesn't happen that way in real life. And in terms of one of the problems that we fall into, I believe, when we talk about concussion numbers, is you're suggesting that all concussions are equal, and they're not. A concussion whose symptoms lasted 6 months isn't the same injury as a concussion whose symptoms lasted 12 days. Gronwell's work was in car accidents, predominantly, and those probably weren't the same things that we're seeing on athletic fields. So I think it's, in generalities, things can be said, but in real life, it's never always or never.
Right, so there's a difference between what happens in a study population and an individual, right? Every concussion is different amount of force, different amount of acceleration. If you look at the mean time to recovery, it's greater in the group that has their second. But for an individual, it doesn't pan out exactly that way. There are studies on EEG and concussion, mostly not what you're asking is if you've had more, do you have changes, but rather when someone has a concussion, are there EEG changes? Yes, there are, and they persist after their symptoms go away, and even in some cases after their neurocognitive function is restored. Now, those are the only ones I know of, so they don't directly answer your question. People have said, well, maybe we should wait till the EEG's back to normal before we clear them. There's a guy named Les Mayers, M-A-Y-E-R-S, who did a whole paper about these sort of adjunctive monitoring, but we don't really know yet which is right.